Salman Kamar, and I am a medical student at the Aga Khan University. The topic for this session is Pediatric Neuro-Oncology, and the chair and co-chair for said session are Dr. Syed Ahmad Hamid and Dr. Shazia Qadri, respectively. The chair, Dr. Syed Ahmad Hamid, is an MBBS doctor with a diploma in child health and an FCPS degree. He is a competent consultant pediatric oncologist with over 17 years of experience in the field and currently practices at Children's Cancer Hospital. He is also an experienced researcher in pediatric neuro-oncology. Moving on to our co-chair, Dr. Shazia Qadri is a consultant radiologist at the Jinnah Postgraduate Medical Center. She is also specialized in cyberknife robotic radiosurgery. Now, without further ado, I would like to invite to the stage Dr. Hamid and Dr. Qadri.
Bismillahirrahmanirrahim. Thank you and good afternoon, everyone. So we apologize for 10 minutes delay in hosting this very important pediatric neuro-oncology symposium. So without losing further time, we should start the session. So first speaker is our Dr. Khadija Nuzat. I would request her to please come to the stage. Dr. Khadija is a pediatric endocrinologist at Aga Khan University Hospital. She is the associate professor, director of the Pediatric Endocrine Fellowship Program, and section head pediatric endocrinology at the Department of Pediatric and Child Health at Aga Khan University Hospital. With several years of experience under her belt and having had a successful career due to her untiring efforts, Dr. Khadija has not only been nominated for, but has been awarded several prestigious awards, include award for the outstanding contribution and academic pursuits in the mentorship and most helpful faculty, Department of Pediatric at Aga Khan University Hospital. So on behalf of organizing committee, Pakistan Society of Neuro-Oncology, on the occasion of 3rd Annual Neuro-Oncology Symposium, we would like to request Dr. Khadija to please start her talk. The topic of her talk will be very important, very close to the pediatricians and young doctors about the survivorship of pediatric brain tumors, endocrinological complications, and its management. With this, over to Dr. Khadija. Thank you very much.
Thank you, Dr. Emmer, for your kind introduction. And also thank you to the organizers for the kind invitation. And I totally agree that this is a topic which is very important for this conference and for all the survivors of the brain tumors. So looking at it, why the endocrine talk about the complications in this session. Look at these scenarios. Look at this. If you relate to that, Meyer, treated for medulloblastoma about 10 years ago, and at 15, is really worried he's the shortest in the class. Ek aur waqia, Sarah, she's showing pivotal changes at the age of 7 years only. She had cranial irradiation when she was 4 for her brain tumor. I'm sure you must have seen these scenarios happening around you in your pediatric oncology clinics. And then a child, Raja. These names are, of course, just dramatized, but these are real stories. 16 years of age, worried about his increasing weight, and dark pigmentation on his neck, acanthosis happening, and he was treated for nasopharyngeal carcinoma at the age of 9 years. So these are the stories that lead us to think the role of endocrinology in the pediatric oncology, especially with the brain tumors. So that's my talk for today. And this is the outline of my talk, and I have no conflict of interest to disclose. So brain tumors, we all know, are the commonest of the solid childhood cancers. About 24% of all childhood malignancies are these brain tumors. And after ALL, they are supposed to be the second most common malignancy in children. And as we are seeing the improving survival rates due to various modalities of treatment, there is improved prognosis. The long-term survival is improving, but at a very serious cost of late effects, which if we are not taking care of, would, make the quality of life of these children worrisome. So why endocrine? It is said that with the brain tumors, about 45% of the complications, the late complications that are happening are the endocrine complications. So just imagine about 50% of the complications that are happening are pertaining to endocrine one way or the other. There are various ways in which we can classify the brain tumors by histology, histopathology, genetics, by their location, whether they are benign or malignant. But for the purpose of this talk, let's assume that what endocrine effects they would be showing. So for me, the way I will classify is those which are arising either in the pituitary or affecting the hormone production by the pituitary. So in this category, all the pituitary adenomas would be there. Of course, it may be a prolactin secreting adenoma, maybe ACTH secreting adenoma. So I'm not going to touch upon that category in this because I think most of those cases are referred to us in the beginning. They come to us and then we include the other modalities of treatment. But cranios are something which we really need to worry about because of their position and their local aggressiveness. They're called benign tumors, but I really wonder if they are benign. The eye effects, the endocrine effects, the effects on the hypothalamus, the psychological effects, they are huge. And then the other tumors arising from other parts of the brain whose treatment affects the pituitary gland, either surgery or radiation or chemotherapy, immunotherapy. That is what I'm going to focus on in this talk. So they are the endocrine complications in the childhood brain tumor survivors are seen early. They may happen immediately after if a child is undergoing surgery. Endocrinology may be needed on board within post-op period. But it also requires, if there are none, it doesn't mean that it hasn't happened. It requires periodic repeated evaluation. And out of all the endocrine complications or disturbances that we are seeing, they will be dependent on the type of surgery that has been done, what was the malignancy like, how was treated, radiation ka dose, what was it, if chemotherapy was used, alkylating agents, the MEK inhibitors, immune modulators, they all affect the endocrine glands. And it is also very important at what age the treatment was initiated. The younger the child, the longer the follow-up is required. And in some cases, the gender is also very important. So let's start looking at how this pictorial depicts in a very comprehensive way where and how the endocrine glands are affected in both the genders. And I'll try and cover most of these in a very rapid manner. And my reference has been the Children's Oncology Group long-term follow-up guidelines. This is a very comprehensive document website, which not only has guidelines available for the physicians to follow, but has also excellent material available for the patients and their parents to look up if you want to give the reading material. So this chart, and the important part for my talk, is the upper part. Just look at it. The cranial irradiation, which is a part and parcel of most of the brain tumor treatment, affects most of the endocrine effects in the body. Every single function involving the endocrine is affected. So let's look at the disorders of hypothalamus and pituitary. Of course, surgery would affect it. Radiotherapy has a very strong correlation about the dose of radiation that has been used in development of the pituitary hormone deficits. And then the immunotherapies like ipilimumab leads to autoimmune hypophysitis. So we may say it does not affect it directly, but in the long term, we may actually see a panhypopit child after the use of this therapy. And all of this leads to panhypopit. And if we don't follow, it may mean a poor quality of life. It may also mean the difference between life and death. This pictorial depicts the dose of radiation and its effect on the pituitary gland. And you see, as the dose goes up, more and more functions of the pituitary are affected. So the most sensitive of all the cells in the pituitary are the growth hormone secreting cells, somatrophs, as we call them. So, but we have to keep in mind that the growth failure that we tend to see in these survivors of childhood brain tumors is not the single effect of growth hormone deficiency, but there are multiple contributing etiologies. Irradiation to the spine and the body, pubertal disorders, chemotherapy, and the long-term use of glucocorticoids may also affect the growth. Then hypothyroidism, poor nutrition, that's severe nausea, inability to eat after chemotherapy and radiotherapy. And to add to that, the chronic renal disease, which is in itself a very potent cause of short stature and is one of the etiologies where growth hormone is supposed to be used. How do we follow that? Because I'm not only supposed to point out what happens, but also lead you towards a little bit about how they should be managed. So what I have done is try to, on one side, give you what leads to it, the etiology in that tabular form, and also how do you follow it. So the guideline says to follow them 6 monthly till the growth is complete. And you all know the growth is completed after the puberty is reached. Otherwise, मैं और आप सारी उम्र, we would have been growing taller and taller. So height, weight, BMI, and Tanner staging. Sometimes we shy away from doing Tanner staging, but that is a part and parcel of the growth follow-up because puberty is an important cause of the growth to progress in a physiological way. And if somebody has not attained puberty, he or she may show growth failure. So if there is poor growth, do check out the bone age. In addition to doing the height weight examination, get to do them a bone age examination. Do check a TSH and free D4. The reason why I am pointing out free D4 in the very beginning, if we have irradiated the brain out, it means the TSH is not coming. So we are talking about secondary or central hypothyroidism, where TSH would not be the marker. Refer to endocrine. I'm sorry about this, but this sentence is going to pop up again and again on multiple slides. Refer to endocrine if you see these problems. So if the height is below the 3rd percentile, or drops more than 2 percentile, we say they are slipping down the centile. So if that is happening, or growth is happening less than 4 to 5 centimeters a year, or the pubertal growth does not happen. These children are some of those who can do very well with the growth hormone, because as we already saw, that they are the first cells to be destroyed by the radiation. So recombinant growth hormone has a very important place to in the treatment of these patients. But it is said to delay the initiation to 1 year after completing the brain tumor treatment, so that we are sure that the disease is quiescent, and also the child has sufficient time to improve the nutrition and all that. But one thing to remember, it's a very expensive treatment. The parents, the family has already gone through the cost of treating a neuro-oncological disease, have gone through the surgery, chemotherapy. So sometimes we are even deferring this treatment beyond 1 year, because to us, the importance lies in saving the life, which may mean looking at the cortisol and the thyroxine, without the replacement of which the child may die. There is also a very huge discussion going on in the literature about the effect of growth hormone on causing second malignancies, but a very comprehensive long-term follow-up has shown that there is very negligible difference, if any, between those who received and those who did not receive in having new tumors developing in the brain. Not only it improves the height, which may have a great impact on the social, cultural outlook for the patient, quality of life, but it also improves the bone mineral density. It improves the cardiovascular function, and also reduces the chances of developing the metabolic syndrome. So after talking about the short stature or poor growth failure, let's talk a little bit about the other way around, central precocious puberty. What happens is there is early activation of the hypothalamic pituitary gonadal axis, and as a result, precocity is seen for a girl child before 8 years of age, and for a boy before 9. And what happens? There are two phenomena. If precocious puberty happens, the child would be a misfit amongst his or her peers. He or she would be shooting up the height centiles, whereas others are still short. But sooner or later, with all that pubertal hormones, the growth plates are going to close, and as a result of which, the final adult height is going to be short. So that is why it is an important aspect that needs to be looked. So we should be screening them for precocity every year till they are sexually mature. In the history, we should inquire about the growth examination. May, as I said to you earlier, the Tanner staging, which in boys must include the testicular volumes. The lab workup, if there is any indication, should include the FSH, LH, and the testosterone or estradiol. If the child is seen to be rapidly growing, then it's good to have a bone age, which would be advanced in these cases. And in girls, an ultrasound pelvis may help for you to decide on the uterine and the ovarian dimensions. So, as I already said, we have to keep following them and refer if they are showing all these signs before 8 or 9 in case of boys and girls. Let's look at the other spectrum, from the hypergonadotrophic to hypogonadotrophic, where the puberty is actually getting delayed or arrested. What happens is the LHFSH, the gonadotrophs are affected by the radiation, chemotherapy, immune therapy, and as a result of which uh, they stop coming in the volume or the amount they are supposed to come. So what do we do in this case? We have to replace. And again, for that reason, we have to replace because of the psychosocial impact, because of the bone health, and also for them to have a normal outlook just like their peers. So how do we do that? We have to check them yearly. Again, puberty का onset check करें, menstrual history देखें, tenor staging करें, and if required, we should check their FSH, LH, and estradiol in the girls till the age of 13, and then follow as is required. And if there is any sign of arrested growth, do refer. Here, the DEXA scan is also very important because we know that these are the hormones, the sex hormones, are necessary for the bone health. Same way, in the males, we have to follow them regularly. Here, we would be doing the testosterone, and since the age difference between the female and male, we will follow them for a year long. And refer if there are any signs of delayed growth. Okay, let's shift gears and talk about the thyroid gland. It's like a driver for the whole body. And sometimes when the patients ask me, I tell them from the skin to the hair, to the menstrual issues in females, to the appetite, to the bowel movement, it has its role in every single thing. From the memory to sleep, it is involved in everything. So it is very necessary that it has to remain under control. Again, yearly check, fatigability, weight gain, cold intolerance, constipation, and skin changes, hair changes, and mood changes. All that should alert you to something is going on. And examination, they may found to have decelerated in their growth velocity. They may have gained weight. So check, as I said, the TSH and 3D4, and refer if endocrine, if found to be low in 3D4, because then we will have to start replacing. We sometimes think that why would the brain tumors have any role in causing hyperthyroidism? But it is a known fact that the scatter irradiation and some of the chemotherapeutic agents do have their effect on causing, instead of suppressing the thyroid gland, causing a hyper effect. There, the effect was at the level of pituitary. Here, it is happening at the level of the thyroid gland itself. So we all know the signs and symptoms of hyperthyroidism, like excessive sweating, lack of sleep, irritability, diarrhea. Any of those present, do check the TSH and 3D4. If there is a nodule, we may have to consider doing an FNA and refer. Here, the treatment modality may need an endocrine input, but also the surgeons, the nuclear medicine people are a very important part of this team. Then we talk about the cortisol. As I said, thyroxine and cortisol are two things which we just cannot ignore. And there was, on the first day of my endocrine training, pediatric endocrine training, my mentor, my supervisor told me that if in a case of panhypopituitarism suspicion, you start thyroxine without looking for the cortisol, then you will kill that child. Because without thyroxine, that slow basal metabolic rate, the cortisol which was there was able to sustain that child. But the day you hit the body with thyroxine, just remember he or she may go into a state of shock, may come into you in a collapsed state. So that is very important to look and screen for hypocortisolism in all children where you are considering starting the thyroxine. How do you look for it? Again, yearly check, ask questions. A very important thing is the fatigability. They tell you they just don't feel like getting out of the bed. They tire very easily. And unlike the primary adrenal insufficiency, they won't tan because there is no ACTH. So if we depend on that finding, they'll turn dark or the nails will turn dark, we'll never find that. So we have to depend on these subtle signs. And if there is any low blood pressures, the cortisol has to be checked at a very specific time because that is the time it peaks. Doing a cortisol at 2 p.m. does not suffice. We have to do it at 8 or between 8 to 8:30 in the morning. Then we talk about something which, just like the thyroid is actually getting increased. This is the prolactin. And why does that happen? That there is lack of suppression of the hypothalamic inhibition on the prolactin secreting cells, as a result of which these children may show hyperprolactinemia. And how would they present? They may present with galactorrhea. This can happen in boys and girls both. The girls can present with amenorrhea. And they may have headaches. So in all these cases, we need to check for the prolactin levels. Slightly raised prolactin is a sign of stress. So somebody who goes to give the blood and is afraid of bleeding may show a slightly increased level of prolactin, but a very high phenomenal increase means there is something wrong going on. Okay. That was anterior pituitary, going on to the posterior pituitary. Unlike the anterior pituitary hormones, they are not affected. The
Dr.
posterior
Khadija,
pituitary.
excuse me, we are short of time.
Just finishing
yeah,
in 2
thank you.
slides.
Sorry for.
So we have to be careful that posterior pituitary is being looked at, and that we have to remember the triple response and close monitoring of fluid intake and urine output is required. So in addition to that, the bone health is very important, and so is the obesity and metabolic syndrome. So we need to be on the outlook for that. And again, these children require regular follow-up. So it has to be remembered that the management is not one single person, it's a multidisciplinary effect. And even the primary care physicians are a part and parcel of this management. As I said, there is this excellent site where the patient reader handouts are available, which can help your patients. And these are my references. Thank you very much.
Thank you, Dr. Khadija, for such an enlightening talk on endocrine in pediatrics. Thank you so much. To our next speaker, Dr. James Drake. He's presenting role of awake craniotomy in pediatric brain tumors. Dr. James is a professor of surgery, division chief of pediatric neurosurgery at the Hospital for Sick Children, and holds the Harold Hoffman Chopper's Drug Mart chair. He is a senior associate scientist at the SICKIT Research Institute, leads the Center of Image-Guided Innovation and Therapeutic Intervention, and is co-lead of the Center of Excellence in Image-Guided Care. Dr. Drake's primary research and clinical interests relate to engineering applications in neurosurgery, including management of hydrocephalus, image-guided surgery, and robotics. This encompasses the main theme of CIG-ITI, which are broadened to include applications of imaging, robotics, and simulation for all pediatric surgical disciplines. Dr. James Drake, over to you.
Well, thank you very much for your kind introduction, and I'm delighted to be involved in the third Symposium for Pediatric brain tumors hosted in Pakistan. And we want to thank Noreen Mushtaq, who remains very well connected to our group here. So I'm assuming you can hear me, and am I sharing am I sharing the wrong screen? I might be sharing the wrong screen. Is this my, are you seeing my full screen, or are you seeing my, the one that is not the presentation view?
I can see your screen.
Okay, perfect. Yeah, so I've been asked to talk about awake craniotomy in pediatric brain tumors. And you might think it's a relatively esoteric topic, and it does affect in our group a fairly small number of patients, but it is actually extremely important, and it gets to the critical team approach to pediatric brain tumor surgery, for which I would say anesthesia is at least 50% of the entire issue. And we're obviously not going to talk about anesthesia in brain tumor surgery, but it is so absolutely important that there's excellent communication between anesthetists and surgeons before, during, and after the operation. And I think this is a great example of how this needs to work to be successful. So I really want to acknowledge my co-authors on this talk, Gabriela Alcaraz Garcia Terhidor, who was a fellow from Spain, who's now back in practice in Spain, who very much spearheaded this recent publication that we had. Tara Durr, who's our neuroanesthetist, who has championed awake craniotomy, and you'll see very young patients. Jim Rutka, my partner, who needs very little introduction in terms of brain tumors. And Sam Stranzis, who's our neuromonitoring specialist, who allows us to do the interoperative monitoring and cortical mapping that is so critical to having this procedure go smoothly. So these are two of the recent publications from our group that I'm going to be discussing. And as I said, this is very much a team dynamic, and I'm delighted to see that James Bolligan, who's one of our former fellows, is now on the program here. So that's just the kind of thing we like to see in terms of Noreen and James going on to great things, having spent some time at Sick Kids. So I thought I'd start with a typical case. And so this is a 7-year-old boy who presented with 2 weeks of progressive hemiparesis and dysphagia. And quite importantly, his dysphagia was not significant enough that we couldn't do interoperative testing. And you can see right away why this could be a challenging case. So this tumor is right up against where we think Broca's area is. We didn't actually, this case, do a functional MRI, I don't think. And the other thing is that the patient has some shift. So this tumor cyst has a fair amount of shift. And when you're talking about doing awake craniotomies and not having great control over the patient's CO2 levels, this is really important. And we're going to talk about our method, which is a little bit different than is often practiced in adults. And that is the patients, they're not awake for the whole procedure. They're asleep, awake, asleep. And that means that you have excellent control over the initial aspect of the procedure. And just in case I forget, the first thing we did when we turned the craniotomy was actually put a needle into the cyst to decompress the cyst, so that when we woke him for the procedure, that we would not have a lot of swelling or mass effect, which could become problematic. So let me know if you can hear him. So here he is. He's 7 years old. He's under anesthesia, and we're doing cortical mapping. And we have a neuropsychologist with us, and we'll get him to go through various methods. So counting is one that's quite simple, but we also get them to carry on a conversation and to identify objects, which are pictures. We also get them to identify animals, lots of different tests to make sure that they're that their language in particular remains functional. So were you able to hear the patient talking there or not?
No, we did not listening it. It is not there.
It was not there. Okay, I'm sorry. I'm not sure how to do that, but the patient, I'm sorry, the patient was counting. And that's the typical setup that we have for the patient in turn. So he's in obviously pins. The whole right side of his body is exposed so that we can test, and he's has an oxygen mask available should he need it, but he's otherwise just on room air. Okay, and so this is the post-op image. It was a Rayleigh fused ependymoma. He was neurologically intact. Speech was normal, and he was treated with focal radiation and chemotherapy. And then he recurred 5 years later, and so he had a small recurrence in the posterior wall of his surgical cavity. And this was treated with a repeat awake craniotomy. And so, he's much older at this point, and it was easier. But the experience for him was not such that he would be unwilling to undergo a second repeat operation. And even though we anticipated there would be some scarring with the tumor up against or the brain up against the dura, and in particular over his speech area. Nevertheless, we were able to get a good exposure, and again, as I said, to repeat the operation. And he's now 8 years out, and as far as we can tell, he's disease-free. So we think that this is the gold standard for patients who are where you can do this procedure. And it is near eloquent cortex, and eloquent cortex is a fairly broad definition, but includes, the motor areas, sensory, speech and language, and vision. So, there are lots of opportunities to interrogate these areas in patients that are undergoing anesthesia. Obviously, most of the experiences in adult patients, and I think the number of patients who would qualify in adults is much larger, and there's a fair amount of literature on this. And Mitch Berger, who was in San Francisco, had really done a lot of very important work on this, showing just how useful this procedure was. I'm also going to talk about Mark Bernstein, who's a neurosurgeon here in Toronto, who has also championed this for many, many patients with brain tumors, both in Toronto, but also in developing countries where actually anesthesia, availability of anesthesia may vary. And it is, if you're very careful and very skilled at this, it is an option when anesthesia is not available. So I do not recommend that for pediatric patients. I think you have to be ready to convert this to a general anesthesia case if things don't go quite as expected, and that's certainly happened once in our experience. And so the mapping is extremely important, and as is the cooperation of the patient. And there are a couple of studies which have suggested that you can actually increase the degree of surgical excision if you do the patients awake. And it's you can use it in a variety of different tumors. They don't need to be benign tumors. You can also do this in malignant tumors as well. And we've done, I think, one patient with a vascular malformation. And again, this is one of those studies which suggested that the results of awake craniotomy are not only as good as under general anesthesia, but in fact, perhaps even a bit better. This was a meta-analysis of 90 clinical trials, and indicating that the results are very good. The incidence of neurological deficits, this is in adults, might be less, as is the incidence of a gross total excision. So I think it certainly allows you to push the boundaries a bit if the patient's awake and you're able to maintain normal neurological function as much as you can tell. I think the thing to be wary of, though, is that if you do get a neurological deficit while the patient is awake, you can't always be guaranteed that it's going to improve, right? So you have to. This has to be taken with some caution. I guess the other thing I can say is that we can not only do the cortical mapping, but you can also map the deep white matter tracts, which is something else that we do. So in terms of the mapping, as I said, we rely very much on our neuromonitoring group, who are really expert at this, and we use intraoperative stimulation very commonly in patients under anesthesia as well. And so I think being skilled at this and using this frequently is important, because there are some issues with the thresholds that you need in order to have a response. It varies with the patient's age, and also interpretation of their language skills. And so knowing that you're not having problems with your equipment, but it's actually a real finding with the patient, is extremely important. And so this is the equipment we use for motor mapping. This is a unipolar electrode. These are the stimulation parameters, which I'm not going to go over in any detail, but we can certainly monitor a large number of muscle groups. And the ones that we have highlighted are ones that are often easier to elicit. And this is another technique that we use, which is, we do trains of 5, and this is an example of eliciting those responses. These are some of the caveats. If the patient has a preoperative deficit, that can impair their response. It can be a little challenging around the central sulcus, and younger children, just because of their brain maturation, it may be difficult to elicit these responses. But certainly in children the age that we're talking about here, 5 to 7, it's usually pretty standard. For speech arrest, we use a bipolar electrode, and we go up to 15 milliamps. And it's important to test areas where you are getting a response, or you're able to impair their speech, and areas where you're not, so you're sure that you are actually having a real effect. It takes a lot of patience to do this properly, and particularly younger children, and having the right amount of analgesics. I haven't talked a lot about the technical aspects of the craniotomy. They aren't that much. We obviously freeze the scalp circumferentially. We don't freeze the dura, and usually the patients have some headache, but it's usually quite well tolerated, and you need to be prepared to give additional analgesics if required. So the pre-anesthetic consultation is extremely important, and that's where the decision is made whether or not we think that the patient is going to be able to do this. In our series, you'll see that our youngest patient was the one I showed you, 7 years of age, but in the past, we've actually seen patients even a bit younger than that, I think down to 5 years of age. The family and the patient need to be very well informed about the procedure, and they may need a real or virtual visit to the operating room just so they're prepared. And so this is the procedure we have landed on. So they have a general anesthetic with a laryngeal mask. And then once we have the brain exposed and are ready to start with the tumor resection, then they are awakened. And that's when we do the mapping and the tumor resection. And then for closing, we put them back to sleep. And that seems to be extremely well tolerated, and as I said, very easy on the patients. We have had some complications. We have cold saline available, or propofol or thiopental. Should we evoke or have a seizure, we can increase the level of anesthetic if we need to. We had to convert one procedure. It was a patient of mine who was from Central America, who's was, I think, 11 or 12, and we had a Spanish anesthetist, and we had a Spanish neuropsychologist, but I think it was just a bit overwhelming, and the patient was also more developmentally delayed. We learned kind of in retrospect than we had anticipated, and so we had to convert to general anesthetic. So you do have to be prepared to do that, and these are some of the other complications you can get into. We have looked at 30 surgeries in 28 patients, and I'm listing there the age range, and most of them were for tumors, which is the subject of this talk, but we have done it for epilepsy and one vascular malformation, and the scalp block and local infiltration I talked about. You're not meant to read this table, but this just shows there's a wide variety of tumors, and mostly related to the speech or motor center, and a large variety of pathologies. And so our brain mapping success has been extremely good. We got a gross total excision in 64%, which I think is quite good. We had some complications, all of which were transient, and we think that if properly planned, this goes extremely well. So I think you're probably not going to be able to hear this either, but this is an older patient who's actually singing and feeling, and I guess you can't hear her, but doing that just because music was extremely important to her, and so that's something you can also test during an awake craniotomy. And the other thing that I'm not totally, I guess, happy with, but anyways, our anesthetist, who's really good at this, will often arrange a video call with the family and the patient while the operation is going on, and we can certainly keep in touch with the family via smartphone during the operation, and sometimes just hearing the parents on the phone and so on really is very reassuring, particularly for the younger patients. So just in conclusion, this is for a small variety of patients, but it can be extremely important and can make the difference between able to get a gross total excision, not getting to one. I can't underemphasize the importance of a very team-based approach here, and very careful planning and experience in not only awake procedures, but also neuromonitoring and mapping. And we continue to, I think, increase the number of patients that we're prepared to offer this to. So thank you very much, and I will stop sharing my screen.
Thank you very much, Dr. James Drake, for an excellent talk on role of awake craniotomy in pediatric brain tumors. So before we proceed to our last speaker of this session, I would like to announce that we have a question and answer session at the end of the third and last talk. So you all are requested to prepare your questions, and all speakers are also requested to be with us at the end to have an excellent question and answer session. So now we proceed with the third talk of the day, and we would like to invite Dr. Mark Karen. Dr. Mark Karen is a distinguished professor, is currently the director of pediatric medical neuro-oncology at the Dana-Farber Cancer Institute and Boston Children's Hospital in USA. He's an associate professor of pediatrics at the Harvard Medical School. His research focused on examining the role of molecular determinants that regulate tumor metastasis. Through multi-institutional trials as a pediatric hematologist and oncologist, Dr. Karen has succeeded in identifying and testing a number of agents in children, and his laboratory continues to advance those novel pathway inhibitors with rapid translation to the clinical practice. So Dr. Karen, we would like to invite you on the stage, and the topic of your talk will be current practice guidelines for pre-irradiated relapse medulloblastoma. So over to you, Dr. Karen.
So thank you very much. Really a wonderful opportunity. Thank the organizers for this invitation. I'm sorry I'm not there in person, but hopefully for the next meeting that will be easier to organize. So as you heard, I was asked to give a talk on the opportunities for treatment in patients with medulloblastoma that have progressed after upfront therapy. And what I'm going to do is just very briefly outline the structure of how we can approach this group of patients that until recently have done relatively poorly. So just for full disclosure, I have recently left the Dana-Farber Boston Children's and now work at a small company, a startup company dedicated to the development of drugs in kids, since that's something that most large pharmaceutical companies are not really that interested in, because I think there's enormous opportunity to translate much of the biology of pediatrics into actual drugs. I will point out, though, that this talk is not related to my role at that company. It's really based on my clinical experience as a pediatric neuro-oncologist. So again, I'm really going to start just with a very brief historical review of medulloblastoma, both for patients that got the standard maximal surgery, craniospinal radiation, and chemotherapy, as well as those that, particularly in infants, that got surgery and chemotherapy-only regimens, and show how that influences some of the aspects with respect to recurrence. And then I'm going to talk about the salvage approaches that are used in patients that have relapsed medulloblastoma, including some of the expanding opportunities in targeted therapies for metronomic low-dose therapies, and then many of the combinations that are now moving forward that combine targeted plus metronomic plus chemo and so forth, just to show you that I think things are finally starting to improve in this patient population. So just starting with a graph that I suspect many of you have seen previously, the Kaplan-Meyer outcomes for patients with pediatric medulloblastoma, again, divided by the 4 groups, WINT, SONIC, Group 3 and Group 4. And given that this is a highly malignant, often metastatic tumor, cure rates of between 75 and 95%, with an average of about 85%, is actually quite good. And that's really been based on the development of this maximal safe surgical resection, followed by a craniospinal radiation that is kind of adapted to the individual characteristics of the patient, and then finally multi-agent chemotherapy. So 85% overall cure rate in medulloblastoma is encouraging. The question is, what do we do for the 15% that are not effectively treated up front, and what do we do with the patients that relapse? And that's what I'm going to focus on. It's interesting that a lot of data from both the Europe, the baby POG and COG studies in the United States, as well as the Head Start studies run by Jonathan Finley, have shown that not everybody needs craniospinal radiation, which is obviously critical for some of the infants. This is an example of a chemotherapy only, where the radiation is replaced by high-dose chemotherapy with stem cell rescue. And as you can see, in newly diagnosed infants, you can avoid radiation, particularly those with nodular desmoplastic subtypes of medulloblastoma, obviously not doing nearly as well in some of the others, and tells us that there's still a way to go. But it does mean at least some medulloblastoma can be cured up front with chemotherapy-only regimens. What happens to those chemotherapy-only patients that do progress? Well, it turns out that if you treat them now with radiation therapy in the hopes that they're at least old enough now to get the radiation, you can see that you can salvage a number of those patients. So any patient that didn't receive radiation up front still has a good opportunity for salvage. For those that don't get radiation, or for those that progress on radiation, however, the prognosis has remained relatively dismal. And that's demonstrated in this retrospective study done by the Duke group many years ago, where they looked at the outcomes of patients that had had standard treatment for medulloblastoma, maximal safe surgery, craniospinal radiation, and multi-agent chemotherapy. In the patients that relapsed, they either treated them with high-dose chemotherapy and stem cell rescue, high-dose chemotherapy with stem cell rescue, as well as a repeat focal or wide field radiation therapy, as well as some patients that just got other chemotherapeutic agents. And what you can basically see, and I think this reinforces the general consensus of the outcome of pediatric patients with relapsed medulloblastoma, is that the majority of patients will do poorly in the intermediate and long term. So you can get some responses in these patients, but as you can see, by the time you're now 5 or 6 years out, things continue to drop, and the vast majority of these patients will end up succumbing to their disease. Very few survivors are identified. And so the question is, how can we improve on that? And obviously, you can't really talk about medulloblastoma or almost any pediatric tumor now without talking about some of the biology behind it. In fact, this was one of the early, what's often referred to as a blue pinkogram, where each column is a individual patient sample. So this was literally hundreds of medulloblastoma samples. Each row is a gene. And you can see that medulloblastoma can sort itself into groups, the 4 major groups that we now all know about, listed here. But as the molecular kind of revolution has taken hold, we don't even think about medulloblastoma as 4 subgroups. We now think about it as many more. And I've circled the ones in sonic hedgehog because that's the one where the targeted therapies have kind of advanced the most, particularly in the context of medulloblastoma. But I think, as we all know, almost every day in the journals, more and more is being learning about the other subtypes, particularly group 3 and group 4. And the hope is that there will actually be some opportunities, targeted therapies for those in the not too distant future. So just to remind people, sonic hedgehog pathway is absolutely critical for actually forming the brain early in embryogenesis, and then it turns itself off once the proliferative capacity has been completed. And unfortunately, in medulloblastoma, a mutation drives it to start proliferating again in the context of a postnatal child, and in this circumstance, the development of medulloblastoma. I'm not going to go through the pathway in detail, but it is important to recognize that there are 3 major molecules that are critically important: the sonic hedgehog ligand, its receptor patch, and smoothen, which are the upstream elements of the pathway. And then these signal through molecules like SUFU and GLI to actually activate the proliferative signal. And the reason I'm talking about this is, as you may be aware, there are many smoothen inhibitors, which therefore should be able to treat anybody with a sonic, a patch, or a smoothen abnormality. Obviously not expected to work in downstream signaling by virtue of the fact that they're below the level of inhibition. And obviously these drugs were not originally developed for pediatric patients with medulloblastoma. They were developed for basal cell carcinoma. This is an example of what we call a waterfall plot, where anything below the x-axis is a response, these patients having complete responses, partial responses, minor responses, and a few with progressive disease. But you can see that these drugs are incredibly active against the same kinds of mutations in basal cell that we also see in medulloblastoma. So smoothen inhibitors have come a long way. In fact, when we think about how to apply them, this is an analysis of medulloblastoma samples from the German group Marcel Kuhl. And what you can see here is, so these are all medulloblastoma broken by age into infant, children's, and adults. For this group here, where sonic, patch, or smoothen abnormalities were seen in about half of the infants and about half of the children and almost all of the adults, one would expect that these patients should be able to respond to a sonic hedgehog or smoothen inhibitor. By contrast, when we look at the downstream elements, the SUFU, the GLI, and so forth, it's just under half of the infants, a very high proportion of children, but very rare in adults. So if you were going to use a smoothen inhibitor, you might think a lot of adults and some infants and an occasional child might respond. So we did run a clinical trial with one of the smoothen inhibitors. There have been multiple trials with other smoothen inhibitors. These are 2 children, a 4-year-old and an 11-year-old with relapsed medulloblastoma after the kind of full standard therapy, craniospinal irradiation, maximal safe surgery, and chemotherapy. And you can see that just on this oral drug, you can get complete responses. In fact, one of these patients is out 10 years, having never received anything after their relapse other than this smoothen inhibitor. So here's a real opportunity to begin to impact the poor outcome in some of these relapse patients. Now, I think many of you in the audience are probably aware that smoothen inhibitors come with a price, in particular abnormalities due to malformed epiphyseal plates as well as growth plate abnormalities. And that's because, well, the sonic ligand activates the smoothen pathway for proliferation of brain cells in your bones. Indian hedgehog actually binds the same smoothen receptor to induce bone growth. And the drug unfortunately inhibits both of those molecules pathways and therefore ends up causing the potential for significant growth retardation in these patients. And that's important, obviously, because as I showed you, the majority of patients are actually either infants, for which this would be a real problem, or adults where we wouldn't expect it would be. And in fact, the EORTC is in the midst of initiating a clinical trial based on the excellent response rate of medulloblastoma to sonic inhibitors, as long as I said that you have one of the three upstream mutations, not one of the ones downstream, is that a newly diagnosed medulloblastoma patients will get the maximal safe surgery, the cranial irradiation, and the multi-agent chemotherapy. But if you have one of those mutations, you will also start to get the sonic hedgehog smoothen inhibitor. So here's an opportunity where we're already moving this therapy, not just in the relapse disease in post-pubertal patients, but now even in the upfront disease. So for kind of other opportunities, because as I've said, we're still waiting for a number of the new molecular pathway inhibitors to come out that may provide some relevance for group 3 and group 4 patients in particular. There are other avenues for both these and other patients. So this is an analysis that was done a long time ago, where, for example, this is a patient that was sent home with palliative therapy due to a lesion right here. In fact, there's widely metastatic disease. What you can see here is that after taking this palliative oral VP16, it's given daily by mouth. It's a much lower dose than would have any likelihood of killing a tumor cell. In fact, most of these patients had already relapsed on intravenous VP16, and it turns out that oral VP16 works by a different mechanism. It basically attacks the microenvironment of the tumor, not the tumor cell itself. And under those circumstances, you can get some very nice responses. Not very long-lived, but certainly some opportunity. In fact, in my prior laboratory, this is an example. These are mouse models of a lung cancer, fibrosarcoma, and a glioblastoma. And again, using very low doses of VP16, you can actually get a complete regression of many of these tumors. Interestingly, even after we had made these cells completely resistant to high doses of VP16, we were able to still get these results, again, because these low dose VP16 doses are not targeting the tumor cell, it's targeting only the microenvironment. That means this only works in vivo, not in vivo, but that's what we care about most. So we've run now a number of trials, a 4-drug trial, a 5-drug metronomic trial, where basically people can just take some of these medicines at home. And we've seen a number of excellent and prolonged responses. And that actually led to this trial that was run by friends and colleagues, Irene Slavik and now Andreas Perl, both at the Vienna Children's Hospital, in which we again took this same concept of the oral VP16 that I had mentioned, oral cyclophosphamide at low dose, the dose that's used for patients with chronic nephritis, thalidomide, a VEGF inhibitor, celecoxib, a COX-2 inhibitor, and fenofibrate, a PPR alpha agonist, with intravenous bevacizumab to shut down the VEGF pathway. And again, when you take relapsed medulloblastoma patients, again, a quarter of which are multiply relapsed, when you take all of the subgroups included, what we discovered was two things. First of all, there was a very high response rate in the tumors. So this therapy is very good at shrinking tumors. And in fact, when you look at the outcome of this patient population, even after 5 years, 25% of the patients with relapsed medulloblastoma are long-term survivors. And so it's no longer a completely incurable disease. And I will say that this group is now is just about to begin a new trial with the addition of another targeted drug to try and further improve this outcome. So another drug that's had a lot of interest in medulloblastoma is temozolomide. This is an Italian study, but there have been multiple other European and US studies looking at this drug in relapsed medulloblastoma. But I think this study kind of summarizes what was seen in many of those studies. And that is that of the 39 medulloblastoma patients, 3 were relapsed PNET. There was a very good response rate. Not quite, just under half of the patients actually had a radiographic response to temozolomide when given in the 5 days on, 23 days off. The problem was that by 12 months, only 7% of patients were still progression-free. So here again is a drug that shows us it can have activity, it just can't sustain it, but raises the question about whether it can be used in other combinations. And in fact, multiple combinations have now been used. This is a randomized study that was just reported from the Children's Oncology Group, looking at patients with relapsed medulloblastoma, in which it was randomized between temozolomide and irinotecan versus temozolomide, irinotecan, and bevacizumab, which I talked about previously as a VEGF inhibitor. And what you can see in this trial is that there is some benefit to the addition of the combination of temozolomide and irinotecan, although still not exactly the numbers we want to see. We're now at somewhere around 15% survival. So not quite as good as we wanted, but at least it shows here's another opportunity of active disease. And again, for every slide, I've included a reference for people that want to go back and look at some of this information. This was an interesting German study. It was interesting for a number of reasons. This is a much more complicated slide than I want to go through, but what you can see over here is they had all kinds of opportunities for patients with medulloblastoma to go on phase 2 window studies to try things to see whether they could get shrinkage and then maintain it, as well as a variety of additional localized therapy approaches as a way of beginning to identify what's important in relapse disease and what's not. And what they discovered in the 93 evaluable patients, all with a medulloblastoma, was, again, the outcome wasn't very good when you just throw standard approaches at them, a standard chemotherapy, suggesting that although they had a good response rate, they weren't able to maintain it. But what they did do is they noted that the patients in first recurrence have a much better chance of survival than those multiply recurrent, but that there were some groups that, particularly those that progressed rapidly after frontline therapy, most in the group 3 was one group that did particularly poorly in any of the approaches they tested, suggesting that group 3 is going to need more. But what they also found was that there was a dramatic survival advantage when patients went back for surgery reducing volume reducing surgery. So even in patients where you knew you weren't going to be able to get a resection of the tumor, just debulking it seemed to make a significant impact on patients doing much better for longer. Similarly, the patients that they re-radiated in a focal area, again, tended to survive much longer than those that didn't get any focal radiation therapy. And then again, in looking at one of their chemotherapy arms, saw some activity with carboplatin and etoposide. Again, a very high objective response rate, almost double that what we were seeing with temozolomide that I showed you before. But again, the problem was maintaining the response rate. And that's where now people can begin to think about how to combine some of these approaches, particularly the surgery and focal radiation therapy, with some of the metronomic stuff that I talked about before. The one other interesting finding from this study was that in the 43 patients that got interventricular therapy had no significant impact on the outcome of that group. They all did poorly, maybe not surprising since they were probably given the interventricular therapy because of disseminated disease. But high-dose chemotherapy with stem cell rescue also had no impact on a positive outcome. So although these are not randomized trials, what we're beginning to see are what are some of the critical elements in an opportunity to salvage a patient that has progressed after standard upfront radiation, craniospinal irradiation, maximal surgery, and chemotherapy. So if you kind of said, where are we in today's kind of state of the art? Certainly medulloblastoma is highly curable at initial presentation following safe maximal surgery, craniospinal irradiation that is adapted to the age of the patient, as well as multi-agent chemotherapy. That while salvage therapy with chemotherapy, both standard and high dose, has a reasonable response rate, it's relatively short-lived, and I don't think really justified anymore, given the cost and the toxicity for something that will not benefit patients for more than a couple of months. But by contrast, there are now a number of targeted therapies, VEGF inhibitors, obviously the smoothing inhibitors, but others coming down the road that may have specific value in certain populations. Again, smoothing in this case being the most important one, particularly if one of your patients is post-pubertal and adult and has one of the 3 most common mutational profiles that would be expected to respond to smoothing. And then finally, what's now beginning to happen Again, you're seeing this with multiple studies. The EORTC study that I talked about, the Mamet study that I talked about, are these combination approaches where people are talking about re-resection, some craniospinal radiation, but then adding in mixtures of some of these metronomic chemotherapy and targeted therapies in the hopes that they will be able to improve the outcome in a higher percentage of patients. And of course, the biggest stumbling block for this right now is we've still not figured out how to actually select patients. When we looked at the 25% that were long-term survivors in the Mamet study, they looked no different from the 75% that were not survivors. And it means that there are other factors here that we still don't quite recognize in terms of who will be optimal for these approaches. But I will say that if a relapsed medulloblastoma patient comes into my clinic now, it's not a question of, time is limited, there's not much we can do. There are things that we can do, and although they're not perfect, they at least suggest that there's some opportunity for long-term survival in a selected group of patients. So I'll stop there, and I think we're going to have a question period with everyone, so I'll leave the questions for that. But again, just want to thank the advisors for an opportunity to speak. So I'll go ahead and stop sharing my screen.
Thank you very much, Dr. Mark Karen, for an excellent talk on the relapsed medulloblastoma. Thank you very much. So now we have three distinguished leaders in their respective field, Dr. Khadija Humayun, Dr. James Drake, and Dr. Mark Karen is there. So we'd like to open the house for question and answer directly from the auditoriums. Participants would like to have any question from our respective speakers. Please open and close up to the mic and ask your question. So they are happy to answer your questions. So anyone from the audience, and please let us know whom your question is directed towards. Those who are on webinar can share as well through local host. There is no question on check box, but from the audience, anyone want to have any question from our speakers? They are. Dr. Therinam.
Thank you. Well, this was a very interesting session. Thank you very much, all the speakers. So I'm a neurosurgeon here, and I started awake craniotomy in Pakistan several years ago, but I've been struggling to start the awake craniotomy for children. So Dr. James Drake, if I can ask you this question, what are the problems that you have faced when you do awake craniotomy for kids below age 13? And how many are we talking about? Maybe I missed that part when you were talking about it.
Yeah, so I don't have the actual breakdown handy, but it is, I think, as you get younger, it becomes more challenging. And, I think the key to this is to having a neuroanesthetist who's really interested in it. And that is kind of very much what helps us. So Tara Durr is not only a superb anesthetist, but has a real interest and is a champion for awake craniotomy. And it really requires a lot of effort in terms of preparation. And we have renovated our operating room just so that we can do this seamlessly, because often the operating room is actually set up with the patient, more commonly looking in the other direction. So we actually had, when we renovated our operating room, we made sure we had all the booms and everything that we can do this with a traditional setup and not turning the room around, which is the other way of doing this. But I think having a neuroanesthetist or anesthetist who has a particular interest in this is the best way of doing this. And also having a neuropsychologist who's also willing to participate. And the tasks can be done by anyone. And sometimes the anesthetist gets busy, so it's nice to have a neuropsychologist there. It also provides some comfort to the patient because they see some familiar faces, even though they're wearing masks. And we also have to have the family on board, right? So it takes a large group to make this happen. And fortunately, we've only had one patient where we had to to convert. But I don't think that it's necessarily, what language the patient speaks. It has more just to do with their overall maturity and general anxiety levels. And I have to say that Dr. Durr is amazing with being able to walk this line between having the patient with adequate analgesia, but still be awake enough to talk. And honestly, sometimes it's like the patients with the older teenagers, it's like they're at a cocktail party or something, right? We can't get them to stop talking. So I think it has much more to do with the anesthetist than probably the surgeon, and also the neuromonitoring specialists as well, who are, again, I just can't say enough about how good they are and how they're able to troubleshoot anything that we're having, just to make sure that if we get a negative response, that is, we don't stop the patient talking, it's a real one, right? It's not just that the equipment's not working properly, we don't have enough amplitude. So I don't think it's as much about the surgeons as it is about the anesthetists, the neuropsychologists, and the neuromonitoring people.
Right. And I think it requires a little female touch too, because, they may have a more calming effect on the kids. So you haven't published that yet, right? Because the publication that I think that we find is a 9-year-old. That's the youngest one.
No, no, it's 7, and we just published that very recently. I did list that in the publication, and I actually have done a 5-year-old way back when. So but it's not just the age; it's the level of maturity of the patient.
Thank you.
Assalamu alaikum. My name is Dr. Mohammed Bari. I'm one of the neurosurgeons. My question is for Dr. Mark Karen. I'm really impressed with your result with medulloblastoma treatment. My question is that you have given SMO, anti-SMO to these patients of medulloblastomas, and there is no recurrence after even 10 years. Can we do it for all of it, or it's only for sonic Hedgehog type, or can we try it against other types of medulloblastoma based on the molecular?
Yeah, so in the trial, actually there were patients that, because this data was still not fully out at the time that was done, we treated any relapsed medulloblastoma patient, and not surprisingly, the only patients that responded were those that had mutations, either upregulation of the ligand, of the sonic ligand, or a mutation in patch, or a mutation in smoothen. None of the downstream patients responded. And so we stopped even treating those patients because we knew based on the evolving data that they were not likely to respond. So here is a case where it really does matter. It's not all sonic, it's not all medulloblastoma, and it's not even all sonic hedgehog activated medulloblastoma. It's got to be sonic hedgehog mutated in either the ligand, the patch receptor, or the smoothen. But when you do those, you have a very high response rate. So much so that, as I've said, it's now actually, the treatment has now moved into frontline therapy in the EORTC study for any adolescent or adult that has one of those 3 mutational profiles of sonic hedgehog and are post-pubertal, so that we don't have to worry about bone.
Thank you.
Is there any other question from the audience? Yes, Dr. Altaf.
So I have 2 questions, one from Dr. James and one from Dr. Mark. My first question is from neurosurgeon, because I'm a neurosurgeon. I was just wondering, have you compared sleep, awake sleep versus throughout awake in your studies, especially in pediatric population and the anxious population of adolescent young population? And do you feel some difference? So this is question directed towards Dr. James.
Yeah, so that's a really good question. And we have different anesthetists that do this. As I said, Tara Durr does most of them, and she's absolutely convinced this is the way to do it. But we have done the patients awake the whole time. I think in terms of anxiety, I think the patients knowing that they're not going to be awake the whole time, they're just going to be awake for a very short period of time during the operation. I think that provides some reassurance to them, and also to know that if the need arises, they can very quickly go back to sleep if, for whatever reason. And so that provides a lot of reassurance. I also think it's a bit faster because, the patient is basically ventilated while you're opening and then while you're closing. And so that you can really move things along very quickly. And, if the patient's having some discomfort, you're not having to stop. And and the interaction with the patient is quite limited until they're actually awake. So, again, just Dr. Durr is really good at having these patients wide awake when you want them. And, and as I said, when they go back to sleep, it's a very light anesthetic. And so having them awake at the end of the procedure versus awake at the whole procedure, I don't think it adds a significant amount of time either. But we haven't done a direct head-to-head comparison. And I know in the adult world, it's much more common to have them awake the whole time. Unfortunately, I'm going to have to leave. I have another meeting. So I just want to thank the organizers very much, and have really enjoyed the symposium again. Thank you.
Thank you, James Drake. You can, yes, no, you can. If you want to go, you can leave, Dr. James Drake, no issue. Thank you. So we have a question from, do you have your second question answered?
I have another question from
Yes,
Dr.
please.
Mark. Dr. Mark, I'm neurosurgeon. I'm a kind of, you can say, naive in these chemotherapeutic agents. But I was just wondering, when you were doing clinical trial, so these patients were not treatment naive. They had a surgery, they had then chemotherapy, which is a standard chemotherapy, possibly PCV. Am I right?
Yeah,
There's-
in North America, we use a slightly different, it's not PCV, no, the standard treatment approach for Medullo. All of the patients had prior maximal safe surgery. All of the patients have had craniospinal irradiation, and all of the patients had multi-agent chemotherapy. The regimens that are most commonly used in medulloblastoma now involve an alkylator, either CCNU or high-dose cyclophosphamide, and all of them get a platinum, typically cisplatin, and then a couple of other drugs. And it's a slightly different formula on the European PSYOP trials from the North American COG trials. The recipes are slightly different for chemotherapy, but they're basically similar. They have a platinum and an alkylator, and all of the patients had relapsed after receiving that therapy. So all of those metronomic studies, the targeted therapy studies that I showed you, those were all in relapse patients for whom the initial craniospinal radiation and chemotherapy didn't end up working.
So my question was related to that specific point. When you have given CCNU and the patient was in remission and then it relapsed.
Yep.
So I think all the patients with medulloblastoma relapse. Am I right?
No,
Eventually.
no. So right now, about 80 to 85% of all kids with medulloblastoma will be long-term cures. They will not die of medulloblastoma. They'll die of old age or whatever. So no, medulloblastoma is a very curable disease at initial diagnosis. Once you relapse, so once you have relapsed, then your prognosis is almost zero. But we've now discovered that some of those relapse patients can be salvaged with some of the assets, the things that I talked about. So it's gone from a highly curable disease front line, but at relapse incurable, to now a very curable disease up front. And some patients in relapse can still be cured. So you shouldn't give up on them just because they've relapsed. They still have a shot at cure.
Okay, so when you and this is the third part of my question. When you segregate two populations who have relapsed to one population, you are giving again standard therapy. and to another you are giving this specific therapy with the inhibitors.
No, so the problem is there is no standard therapy for relapse, only because until these studies came about, and the Mehmet study is just being published. So I showed you the data, but that's not even published yet. That'll be coming out soon. Is once you relapse, you are considered incurable. So there is no standard therapy. As you can see, people have tried multiple different things with some success, particularly in early responses, but it's been hard to maintain. We're just now reaching the point where we're beginning to actually see some long-term survivors from some of these new approaches. So I think the idea is when somebody relapses, every doctor decides what they're going to do to try to palliate these patients. Obviously, if a child's already had craniospinal radiation, you can't go back and redo craniospinal radiation. So the re-radiation is typically a lower dose and typically just more focal around the area of relapse. But with repeating the operation by the neurosurgeon, even if you know you can't get it all out, just debulking the tumor appears to provide a longer event-free survival. Re-irradiating the place where the tumor has come back seems to prolong the event-free survival. And now with some of these metronomic approaches, some of the patients actually appear to be long-term cures, only about 25% of them, but it means some of these patients can be salvaged. But there is no standard therapy. So every physician has to make their own decision about how they're going to treat a relapsed patient.
Right, thank you. And when we are going to get this FDA approval for these inhibitors?
Well, so the sonic hedgehog inhibitors, and there are multiple. Sunitinib, the one that I presented, is just one of multiple inhibitors that are already FDA approved. They're approved for basal cell carcinoma. And as I've said, the European cooperative EORTC is in the midst of doing a large clinical trial of now moving it up front, not just in relapse, but the drugs are already available for patients with specific sonic hedgehog mutations.
Thank you, sir.